Today is August 27, 2024. Welcome to SEVA VentRounds. Today we're going to talk about expiratory waveform and a little bit about the analysis of the expiratory waveforms. The disclosure is that it's no endorsement of any mode, ventilator, or manufacturer. Whatever we say, it's our opinion. It does not represent the Cleveland Clinic. I'm one of your hosts, Eduardo Mireles, and Rob Chatburn, who you can see on the screen. There you go. Those are conflicts of interest. Remember, this is a recorded session, so just keep your microphones muted. However, if you want to speak at any time, go for it. Have no fear. Unmute yourself and talk to us. Or if you want just to put it on the chat function, that also works very well for us, and we are all monitoring all the time. Okay. There are CRCE and CME for those that are staff or in the Cleveland Clinic. So please stay and fill up your evaluations. So this is a classic image that we have regarding the expiratory waveform. And as you well know, part of the SEVA training that we generate is to focus on the waveforms. And during the expiratory phase, the ventilator is controlling the pressure. And so it's essentially a pressure control phase. And we would have, in normal circumstances, we would expect a passive expiration. So what will happen is when there's the step decrease from inspiratory pressure to the PEEP level, then you would have the exponential decay of the flow waveform, as you see here on this green line, along with the dotted line, which represents the ideal. And so you can see that both match. That's a passive normal load situation. In the next case, you have now a patient that has PMOS present, and that manifests as the moment that there's the step decrease. Instead of having this beautiful exponential decay that you would be looking in a passive expiration, and you see here by that dotted line, green dotted line, now you have that area that it's actually the waveform. You can see how it moves away from the baseline and away from that expected flow waveform, and all this area signifies that the patient is doing an amount of expiratory work. So it's activating the expiratory muscles. Rob, comments?
Yeah, there's information in the peak expiratory flow as well. Peak expiratory flow is equal to the plateau pressure minus the set PEEP divided by expiratory resistance. So in other words, if the expiratory resistance goes up, the peak expiratory flow will go down, meaning closer to zero.
That's wonderful. That's a great point. And so the next one actually, and Rob, you could comment on that as we see the next one. The next one is now a patient that has expiratory resistive load. So the resistance is increased during expiration. And here, even though it moves away from that expected exponential decline, it's still exponential, but it just takes longer for the patient to get there. However, here the peak flow is less than expected, as you can see from the dotted line. So Rob, can you comment on that? Why is this the case?
So again, the peak expiratory flow is equal to the plateau pressure minus the peak plateau pressure minus the set PEEP divided by expiratory resistance. So I'm not sure if the plateau pressure and the set PEEP was the same in this particular simulation, but let's say it was. Then if the inspiratory or the expiratory resistance goes up, then the ratio of pressure to resistance goes down, and therefore the peak flow has to be less. Furthermore, you see an exponential curve. It just has a very long time constant. And you recall that the time constant is resistance times compliance. If the compliance stayed the same and the resistance goes up, the time constant goes up, which means that it takes longer to exhale 63% of the tidal volume.
And an important thing for us to recognize is, and this causes sometimes challenges in our learners, is that they see these oscillations and these little changes on the waveforms. And I would just highlight that as the gain improves or the sensitivity or the sensors get better, you will start detecting stuff from cardiac oscillations, muscle activity, or other items that will make some aberrancies on your waveform. But in general, if you see it, you can see the exponential decay occurring throughout. And in the last waveform, now you have here a patient that has an elastic load. And these are actually from patients. So Rob, you're right. This is not a simulated waveform. This is from patients. So you could argue that there's not the same situation. But you can see here how it would look, the exponential decay on a normal circumstance. And now you see it reaching the baseline even faster than before. So that's how you can see that. All right. Anything else, Rob?
No, just the peak expiratory flow was higher because the resistance was less, and the time constant is less as well.
Excellent. We often will comment. A good thing for you is remember that you have the volume waveform, and the volume waveform carries the same information that the flow waveform, but it's amplified. So sometimes it's hard for you to see if it's reaching baseline or not, and you can look at the waveform, and this will essentially amplify that and give you it's a different perspective, let's say, and so you see it bigger and better. So here's our case for today. And again, Ariel, I know you hate pictures from the ventilator and you would like a very nice picture coming out. But these are older pictures, but I thought that this would be a good high quality example for us to analyze today. So do we want to start with the tag by the team? What's the tag for this patient? I'll put it on the chat. Have no fear. All righty. So we're starting to see some items. So at least the tag to start, you can see the mode here, and it says volume control. And this would be one of those in which you may fall into a little bit of concern. So normally a volume control, as we understand it, as when I say volume control, or when you read volume control on the literature, normally what we are talking about is the following tag, which is VCCMBS. That's if you would ask the majority of practitioners, when we talk about volume control, we talk about controlling the flow. However, when you take a look at the waveforms, and Michael, you have recognized the issue. The part of the issue here is if you're in volume control, as we recognize it, you would expect the flow to be controlled, and you can see breath number 2 and breath number 3 and how beautiful the flow is controlled. And however, on breath number 1, you get concerned because you see now a bump that you were not expecting to see. So there is now evidence of the flow is not as it should be. And this is a classic manifestation of that there's a different targeting scheme. So something else is happening. So if you use the bend mode app that we have, or any of the documents that we have put there, this is a servo ventilator, as Ariel has pointed out there, or Rob has pointed out there. So this is not our classic CMBS, but it's actually a type that we call IMB type 4, and it's dual and dual. And that means that the if the machine recognizes the presence of PMOS, so effort by the patient, which you actually can see on the pressure, we're gonna get there, it actually changes from volume control to pressure control, and it frees the flow so that the patient can get, will not work shift as much. And so that's what you see there. Rob, comments?
Yeah, when you say pressure control, there is a built-in target for that pressure control. And as far as I can tell, it's a PEEP or a round PEEP. So in other words, the ventilator frees up the flow so that the airway pressure doesn't drop below PEEP. As you can see, it tried to do up there when the ventilator then released the flow. And so the pressure then got above PEEP again.
And it's important for you to recognize that there is, and this is important because if you're looking at the patient ventilator waveform, that's an important finding, and there, it explains a series of things that we're going to talk in a second. But the second part that I want you to be aware, even though there's several forms of dual control or different implementations. This is how it's implemented on this ventilator in particular. There's different targeting schemes for dual out there. In this case, it's related to the presence of PMOS on volume control. Any other comments?
Yeah, in general, there's two kinds of dual targeting. One, where you start off in volume control for a breath and end up in pressure control like we see here. And there's a couple of ways you can do that. The other is you start off in pressure control, and if you don't hit your target tidal volume by the end of inspiration, then it goes into constant flow volume control. So there's like at least 3 different ways you can see it.
Correct. Alrighty, so now that we have this mode here, and we'll come back in a second to talk a little bit more of why would you use this and what would be the items, but let's move on to what is the load. So during inspiration, what's the load? And during the expiration, what's the load? Yeah, so we're starting to see, so some of the members recognize the presence of PMOS during inspiration, and then during expiration, the word that comes is resistance. Okay, so that's what's coming, and I get a little happy face. So let's analyze this for a second. And so we recognize that there is evidence of PMOS here. I mean, we talked about it, this change from constant flow to allowing the flow to go up because now we're on pressure control is a manifestation of PMOS. There's other places where also we see PMOS, and I will just highlight for a second, and we're gonna get back to this. But if you see the height of this pressure waveform over here and over here, the only reason why this would go down, it's either the compliance improves on the patient or there's PMOS. And there's a little bit of evidence of PMOS if you notice the peak flow, as we were pointing out, you see how it's amputated here. And on this one, in which it seems to be passive, it's very nice. You see that? So there's evidence of PMOS here. So I think Michael is absolutely attuned to this, and there's evidence of PMOS during inspiration. In the last breath, there doesn't seem to be much PMOS, but either it didn't break through or it could have happened, but just based on what I'm seeing, I suspect that the load during inspiration is probably more tending towards elastic, just based on what I'm seeing here. But then during expiration, you talked about resistive. Rob, do you want to talk a little bit about that? What do you see? Why is this resistive and not PMOS, or why is this PMOS, or is this PMOS in the face of resistive?
Well, the way I would read it is if you start from the peak flow to the next breath, you're looking at 1, 2, about 3 seconds, right?
Yep.
So that's a long time to exhale. So that would indicate either a high compliance or a high resistance. And we like to say that it's generally high resistance when there's a long time constant. But if you look at it, it's not smooth, right? There's little bumps in there. Right there, and right there. Those little bumps look to me like cardiac oscillations, and sometimes that can cause false triggering. If they were PMUS or inspiratory efforts, I would expect them to last longer. Those just last like a tenth of a second, real quick. PMUS
Yeah,
generally.
there's some that are small, but there's others that are a little bit bigger, Rob. That so
Yeah,
you see this one, how this one looks here, and this one looks here, and this
yeah,
one
yeah.
looks
You can see
here.
that too. Yeah, they could be superimposed. Yeah.
Yeah, so I think that there may be, I mean, this seems to me that the patient is activating the expiratory muscle. So it's going actively with, I mean, this would be consistent with increased resistance. And actually, I'm going to
Mm-hmm.
amplify for a second because this has been described. So you see how suddenly it
Yeah,
goes to zero,
yeah. It's
and the
easier to see
same.
that way, right?
Yeah, so I think that when you see this, and actually this is a form, it's not happening here, but there is some false trigger that occurs from relaxation of the respiratory muscles that can occur. Not in this case, but this has been described. The patient is actively exhaling, and then it relaxes the muscles, and even though it's not causing inspiratory effort, boom, it triggers another breath, which you don't see here. So I think that this is definitely very concerning for expiratory resistance or activation of the expiratory muscles on a patient with resistive. So I would put that it's both. And I agree, there's cardiac oscillations. I'll erase that so that we can see them a little bit better again. And you can see those cardiac oscillations right here
Mm-hmm.
that Rob pointed out very well. Any comments from the team? Okay. All right. So now we move on to PV discordance. So let's talk about the trigger. What do we see in terms of trigger? So is it normal, early, late, false, or failed? We know there's PMOS, so something is going on here.
It's hard to see, Eduardo, but it looks like there's no change in color of the red or the yellow curves. Is that right?
That's correct. There's no change at all. Yeah, so that's correct. So this is the classic pattern that you should be looking for when you see evidence of PMOS during inspiration. Your eyes should then move back to look at what triggered the breath. And in this case, we don't see any change. Actually, you don't even see a drop in pressure in any of those two breaths, right? And the flow is not crossing above baseline, and there's no change in the flow waveform. So this is an early trigger on breath 1 and 2. And I know that it's in breath 2, even though I don't see the change in flow, but you see the difference in height on the pressure waveforms. And this is very subtle, right? It's very subtle, but there's another feature of PMOS available for your eyes here, and it's the fact if I would draw PMOS on this patient, on this I'm going to draw a line instead of the usual draw, but where there is PMOS on this patient is probably from here to around here, inspiratory PMOS. And I know that because the pressure drops and then it opens the valve, right? On this one, I would say that the PMOS probably started around here and then it's around here. And I know that because the expiratory peak flow is gone. And the absence of the expiratory peak flow tells me that it went there. The last one, I don't see any evidence of PMOS. So these two
Well,
are
I don't know about that, Eduardo, because the pressure waveform, once it reaches its full flow, it should be a straight line, and it's not, right?
where? No, I don't.
If you have a constant flow,
yeah.
once the flow reaches its peak value, then the pressure should be a straight line. On the pressure waveform, see it's curved, just like this, the second breath.
This one.
No, that's the third breath.
Oh, the third breath.
See, it should be a straight line from there on, because the flow is constant. Pressure has to rise.
Can I say something?
Yeah.
I agree with you. It should be a straight line with the PIP way higher. So it seems like that part is scooped by the reverse trigger breath. Also, that the contraction lasts longer and makes the peak expiratory flow lower compared to third breath.
So you're saying that it's like this amount?
It should be.
Yeah, that sounds reasonable to me too.
Okay.
And also there is something like the flow doesn't increase to 90 degrees, so we cannot observe normal pressure waveform that we usually observe with the initial step.
Yeah, what you're saying, Ariel, is that the rise time on this ventilator, you can set the rise time for both pressure and flow. The rise time is set in milliseconds. In this one, if it was 0, it would be perpendicular, like Ari just said. So it's set probably by default to be like 0.1 or 0.2 milliseconds or 0.2 seconds. And so therefore, you don't see that. It's a slanted rise in flow, and that causes a slanted rise in pressure as well.
And so I just drew, just for the sake of clarity on the discussion here, what you can
That's
see
what I'm saying.
is that the rise time on flow, and don't ask me what's the benefit of changing the rise time on a passive patient in general, but whatever. So for whatever reason, we decided to do that. But this should be a square, the same way that it goes down here, it should be going up right here. And so we changed it that, and because we changed that, the rise time or the resistive component, usually we would see a very straight line that would go up on the pressure. And instead of that, we see this slanted rise because the flow is going up. And then what Rob was mentioning, and I agree completely, is that because the flow is constant over here, we should have a straight line, and then it would depressurize. But instead of that, we have this waveform that looks essentially like a little semicircle. And this area that is missing here is probably the presence of PMOS right here. And then it's a very small PMOS, and then boom, it relaxes and the patient exhales. So I fully agree with that, Roberto.
Good.
All right. Very nice. Very nice. You see, every time, the more we look, the more we find. And so now we would not evaluate the inspiration because the problem is the early. So this becomes a little bit mute when you have early trigger. And the same happens with cycle, because early trigger will cause inspiratory and cycle aberrancies. But when we come to expiration, and we already talked about it, we see evidence of some degree of PMOS that it's occurring during exhalation, which could be PMOS or just high resistance. But I'm suspecting, just given those big undulations, that there is some activation of the expiratory muscles. So the question that I have always at the end of this is, well, how do we deal with this? How do you approach this? Now you have read this, you recognize this patient has early trigger. You look at this ventilator waveform. The patient is set at 380. It's getting around 412, not that terrible. But there's evidence of PMOS during inspiration and during expiration. And so this question always comes of what do you do with it? And I think that the framework that we like to use is to ask yourself is, what is your goal? Is your goal safety or comfort? If your goal is safety and this patient is coming out of sedation, you may be okay and you may want to tolerate this. That may be doable. You may consider, well, maybe I want to decrease the rate on this patient so that this gets better. But if your goal is safety, comfort, then you may want to consider using other modes that may allow you to have a better patient interaction in the presence of early trigger. But most of the time when we're waking up a patient, we will see some degree of early trigger. And you have to decide what are you going to do with that patient. Do I just write it if it's not doing major harm, or do we need to change it? Do we fight it? Or do we sedate the patient again?
So, Eduardo,
Yes, sir.
something I would love to bring into this present is the use of a PEEP of 16 in a patient already obstructed with a respiratory rate of 16. How do we know if the PEEP, in this case, is helping this patient or not?
Explain a little bit more.
Because we are using a PEEP of 16. We may, based on the graphics, we might have some sort of air trapping. So, and sometimes, depends on the level of PEEP, you can worsen the air trapping, or you can improve the emptying by sprinting the airways. So at this present time, it's like, I don't know if I would use a PEEP of 16 in a patient showing this level of obstruction.
Yeah, I think, I mean, the challenge of just looking at this waveform without any clinical background is that it would be very hard for me to make a statement regarding the PEEP appropriateness or not. I would say that at this point, what you have evidence is of expiratory work. Now, and I don't see high resistance during inspiration. So is that valve mechanism? Is this floppy airways? I mean, we could go through several areas. That's a good point. Is this the right PEEP for this patient? I don't know. I could not tell you at this point based on this waveform. But it's a good question. So I don't see any other questions here. But so in summary, BCIMB4DD, or in this case, when you have the dual targeting for this mode, may be okay in some patients in which what you're doing by doing this is you are allowing the patient that if there is enough PMOS to change from volume control to pressure control. And that may be okay. That may be aligned in patients that are waking up, and you don't want them to have inappropriate or double triggering, as this mode will change into spontaneous modes. That's the benefit of this IMB type 4. We also talked about the early trigger and how it looks as you're controlling flow, the change in pressure, and the very good and pointed comments regarding what we would expect to see. And that's the importance of when you're training yourself to read waveforms, you have to know how this looks normally. And when you know how it should look, then you can find the abnormalities that are there. And yeah, that's what I would say. Those are all great things. And we saw some amount of expiratory work. The cause still to be defined. And Ariel brought up some questions regarding, is that PEEP appropriate? And I cannot give right now that comment.
Eduardo, I must correct myself because it could be an obese patient, and I guess I rushed into talking about it. So I could be completely wrong.
Yeah, that's why I said you can't make an assessment without the history, and that's one of the limitations of this, Ariel. So that was implied. Here are the CME for CCF caregivers, the CRC for RTs. That's the code for you to claim your CMEs. And as usual, here is our resources, prior episodes. I think this is episode 78. And thank you very much for attending, and see you soon. Thank you all.